Welcome everyone to today's May webinar entitled Anticoagulation During Pregnancy. Next slide. There we go. We're excited to welcome today Dr. Maria Teresa DeSancho, Professor of Clinical Medicine and Clinical Director of Benign Hematology at Weill Cornell Medicine and New York Presbyterian Hospital. I am one of your moderators. I'm a Clinical Pharmacy Services Manager at Kaiser Permanente. We also have the pleasure of introducing, Dr. Andrea Van Beek, Anticoagulation Clinical Nurse Practitioner at Visalia Medical Clinic and Kaweah Health Medical Group. And with that, I will hand it over to Maria to present for us on anticoagulation during pregnancy.
Thank you very much to the Anticoagulation Forum for giving me the opportunity to give this presentation today. These are my disclosures. The outline of the talk includes to discuss risk factors for venous thromboembolism in pregnancy, to understand the recommendations for pharmacologic thromboprophylaxis in pregnancy, to delineate the optimal dose of prophylactic anticoagulation during pregnancy and postpartum period, and to describe the management of acute VTE in pregnancy. The risk of VTE is enhanced 4 to 6-fold in pregnant women versus non-pregnant women of similar age. Among reproductive age women, the risk of VTE is 1 in 10,000 compared to pregnant women, which is 1.2 in 1,000, with a case fatality of approximately 0.41%. According to the World Health Systematic Analysis publication, VTE was accountable for approximately 14% deaths. VTE remains a leading cause of maternal mortality in the United States, accounting for 9.3%. From 2006 to 2012, there was an increased VTE incidence during vaginal delivery hospitalizations from almost 16 in 100,000 to almost 30 per 100,000. In a meta-analysis, 2/3 of the DVT happened in the antepartum period and were distributed equally among all the trimesters. In another study, the risk of VTE appears to increase exponentially as the pregnancy progresses. Importantly to know, 40 to 60% of the pulmonary embolisms happen in the postpartum period, specifically if the mode of delivery is a C-section, mostly emergent C-section. So what are the risk factors for VTE in the setting of pregnancy? There are anatomical, there are physiological, and coagulation factors that influence the risk of VTE, causing the perfect storm already postulated by Virchow. These include decrease in the venous flow velocity by half in the legs by approximately 25 to 29 weeks of gestation and persist throughout the entire postpartum period. There is also venodilatation induced by progesterone. Also, there is compression of the pelvic veins by the gravid uterus. And a very important point is that the left iliac vein is compressed by the right iliac artery. Therefore, in pregnancy, it's most common to get DVTs in the left lower extremity. So what are the risk factors from the coagulation standpoint that happen in the pregnancy? There is an increase in procoagulant factors, namely fibrinogen, factor 7, and factor 8, as well as von Willebrand factor that increase during the pregnancy. In addition, there is decrease in anticoagulant proteins, specifically free proteinase, that remains low through also the postpartum period. Antithrombin is also decreased in the immediate postpartum period, and there is also a decrease in activated protein C resistance. In addition, the fibrinolytic system is impaired because there is an increase in plasminogen activator inhibitor type 1 that is coming from the endothelium and pi2 coming from the placenta. The D-dimer also increases throughout the pregnancy, and there is an increased tissue factor. All this is to prevent excessive bleeding at the time of delivery. But what is the main risk factor for VTE in pregnancy? The main risk factor for VTE in pregnancy is a personal history of VTE. In this case, the risk could be up to 4.2% without any prophylaxis. Important to recognize that if the pregnancy is assisted with in vitro fertilization, specifically if the embryo is transferred fresh, the risk is increasing also by 8-fold, mainly on the first trimester of the pregnancy. Autoimmune diseases such as dermatomyositis, systemic lupus erythematosus, and also sickle cell disease and age 35 and above increase the risk of VTE as well. What about hereditary thrombophilias? Hereditary thrombophilias, specifically homozygote for factor V Leiden and the prothrombin gene mutation, even in asymptomatic individuals, increase the risk significantly. On the third column, you can appreciate that in the presence of a positive family history, the risk really doubles or sometimes triples. And definitely, if the person has already a personal history of VTE, the risk is significantly enhanced. So, what do we tell women when we are pregnant? I think it's very important to tell all women that pregnancy and the postpartum period increase the risk of venous thromboembolism. Specifically, women at high risk need to be counseled on signs and symptoms of VTE, not just during the pregnancy. They should be aware of this even before the pregnancy. And when we see them during pregnancy, every trimester, we have to let them know about this, including also the postpartum period. And we should all have a plan just in case this happens. So I will start with the patient of mine that I followed. She was a 32-year-old female with a history of left lower extremity DVT, which happened in the setting of taking birth control for a total of 10 years. She was treated with rivaroxaban for a period of 3 months. After completion of the anticoagulant treatment, she had an ultrasound that showed no residual thrombosis. Past medical history was significant for a sister who had a DVT in the setting of arthroscopic knee surgery. The patient was tested for thrombophilia, and she was identified to be a carrier for factor V Leiden. What will you recommend for VTE prophylaxis during pregnancy? So these are the options. A, close monitoring of VTE symptoms without anticoagulation. B, serial bilateral leg ultrasounds and treatment only if she has a DVT. C, anticoagulant prophylaxis only during pregnancy. D, anticoagulant prophylaxis only in the postpartum period. E, pregnancy and postpartum anticoagulation prophylaxis. F, participation in the Highlow clinical trial. We had at that point this trial available in our hospital. So what about the guidelines? What do the guidelines tell us? The American College of Chest Physicians, published in 2012, recommend antepartum and postpartum prophylaxis in women with a single unprovoked episode of VTE, or if the VTE was related to a hormonal risk factor, or if the VTE was related to a minor non-hormonal risk factor, such as a flight or a small trauma, or women with a history of multiple unprovoked episodes of VTE who are not on chronic anticoagulation, or if the VTE was related to a persistent risk factor. On the other hand, postpartum prophylaxis only for 6 weeks is recommended to women with a history of a single episode of VTE related to a non-major hormonal transient risk factor, such as a surgical procedure. The American Society of Hematology in 2018 has similar recommendations. So antepartum and postpartum prophylaxis in women with prior history of unprovoked or provoked by a hormonal risk factor, and on the other hand, a provoked VTE non-hormonally related, then only postpartum prophylaxis. keeping in mind that these recommendations are based on a VTE risk threshold of 2% antepartum, 1% postpartum. So what about women with hereditary thrombophilia with no history of VTE? Important to note that women who are protein C or protein S deficient in the presence of a family history, then postpartum prophylaxis is indicated. Antithrombin deficient patients with a positive family history should receive antepartum and postpartum prophylaxis. Women who are homozygous for factor V Leiden or who do have combined thrombophilia should receive antepartum as well as postpartum anticoagulation. On the other hand, homozygous for prothrombin gene mutation in the presence or absence of a family history should receive postpartum prophylaxis. Importantly to realize here that the no formal recommendations is based in the fact that there is no family studies with homozygosity for prothrombin gene mutation. And the quality of the evidence for these recommendations is considered to be low. What anticoagulations are considered to be safe during pregnancy? Both low molecular weight heparin and unfractionated heparin are safe as they do not cross the placenta. Low molecular weight heparin is the preferred anticoagulant because it causes less decrease in bone mineral density and lower risk of heparin-induced thrombocytopenia, which is not a common complication in pregnant women, although thrombocytopenia happens frequently, specifically in the third trimester of the pregnancy. Fondaparinux is used in situations in which the woman has a history of heparin-induced thrombocytopenia or is allergic to all preparations of low molecular weight heparin and unfractionated heparin. Vitamin K antagonists are not indicated in pregnancy except in women with mechanical heart valves, in which these agents are used on the second trimester of pregnancy. And the direct oral anticoagulants also cross the placenta and should not be used in pregnancy. The International Society of Thrombosis and Hemostasis published a guidance in 2016 regarding DOAC exposure during pregnancy, and it's recommended avoidance of pregnancy in women of childbearing age taking DOACs. If the pregnancy is desired, the woman should be switched to a low molecular weight heparin, or they also recommended a vitamin K antagonist. If unintentional pregnancy happens, the DOAC should be immediately discontinued and the patient should start low molecular weight heparin. They also didn't see the need for an elective termination of pregnancy, but they highly recommended early obstetric and fetal monitoring. And if a woman is exposed to a DOAC during pregnancy, this should be reported to the manufacturer and to the ISTH registry. In 2020, a large retrospective cohort study was published with a total of 614 individual exposures to DOAC in the setting of pregnancy. Of those, there were a total of 336 cases with available outcomes, and one of 88 of those 336 had live births, 74 miscarriages, and 74 elective termination of pregnancy. The most common anticoagulant used in this registry was rivaroxaban, but the rates of fetal abnormalities were reported to be 6%. However, potentially associated with DOAC exposure, the number was lower, 4%. This makes a difference with approximately 7 to 10% if the woman was on a vitamin K antagonist. The authors didn't also find a high risk or a distinct pattern of embryopathy with the direct oral anticoagulants, and they corroborate the no need for elective termination, but early obstetric and fetal monitoring if a woman has been exposed to a DOAC. So what do the different guidelines recommend for thromboprophylaxis in pregnancy? So the American College of Chest Physicians, American Society of Hematology, American College of Obstetrics and Gynecologists, and the Royal College of Obstetrics and Gynecologists all recommend low molecular weight heparin. There are few differences. The American College of Chest Physicians suggests either prophylactic or intermediate dose, while the American Society of Hematology suggests a low dose, and the American College of Obstetrics and Gynecologists, they suggest either a prophylactic, intermediate, or adjusted dose. And the Royal College, the dose is based on the patient's weight. In the postpartum period, all of them suggest either a prophylactic or an intermediate dose. The American College of Chest Physicians also suggests to switch to a vitamin K antagonist to maintain the INR between 2 and 3, and this duration in the postpartum period should be of 6 weeks. So based on these different discrepancies, a group of investigators decided to design the Highlow clinical trial. So the Highlow clinical trial, the objective was to evaluate a weight-adjusted intermediate dose low molecular weight heparin versus a fixed dose low molecular weight heparin among pregnant women with a history of VTE. The hypothesis was that the intermediate dose will be superior to a fixed dose in terms of recurrent VTE with a comparable safety profile. On the top, we can see the design of the study. The study was a multi-center international open label study, and women had to be included when they were below 14 weeks of gestation, all had a history of VTE which was either unprovoked or related to a hormonal risk factor. They were randomized to either an intermediate dose or a fixed dose, and they were followed throughout the pregnancy, and then 1 week, 6 weeks, and 3 months postpartum. In the lower part of the slide, I have highlighted the low dose, so just for enoxaparin, since this is the most common type of low molecular weight heparin prescribed in the United States. For women who were below 100 kilograms, the dose was 40 milligrams. If the women were 100 or more than 100 kilograms, was 60 milligrams once daily, while the intermediate dose varied according to the weight. For women less than 50 kilos, the dose was 60 milligrams, women 50 to less than 70, 80 milligrams, women between 70 and less than 100 milligrams, and more than 100 kilograms or 100 kilograms, 120 daily. And in this group, dose was adjusted if the weight of the patient was increasing throughout the pregnancy. The inclusion criteria were pregnant women, 18 years of age or above, history of VTE, and a gestational age of 14 weeks or less. The exclusion criteria were VTE related to a major risk factor, indication for therapeutic dose anticoagulation, and contraindication for low molecular weight heparin. The primary efficacy outcome was objectively confirmed symptomatic VTE during pregnancy up to 6 weeks postpartum. Primary safety was major bleeding, and the secondary efficacy outcomes included composite of objectively confirmed VTE or superficial thrombophlebitis at any time from randomization up to 3 months postpartum. The secondary safety outcomes were composite of major or clinically relevant non-major bleeding, non-major bleeding, minor bleeding, maternal mortality, allergic reactions to heparin, HIT, congenital anomalies, or birth defects. So the study was conducted from April 2013 to October 2020 and included a total of 1,339 pregnant women screened. Of those, 1,110 were randomized, 555 to the intermediate dose and 555 to the low dose. On the left panel, you can see the characteristics of these patients. The mean age was 32. Most women were between 50 and less than 100 kilograms in the middle panel. Approximately slightly less than 50%, they were on low molecular weight heparin prior to the randomization. In terms of the previous type of thrombosis, approximately 50-50 were either pulmonary embolism or upper or lower extremity DVTs, and approximately slightly less than 60% in each group. The reason for the previous VTE was hormonally related. 25% on the right panel in each group had a known thrombophilia, and the two most common types of low molecular weight heparin administered were enoxaparin followed by nadoparin. In terms of the primary outcome, venous thromboembolism was similar in the intermediate dose, 2%, versus low dose, 3%. But we have to keep in mind that pulmonary embolism was slightly more common in women assigned to the low dose, and the pulmonary embolism happens most commonly in the postpartum period. Looking onto venous thromboembolism or superficial thrombophlebitis was also more common in the women that were assigned to the low dose, and this was also statistically significant. And the same was applicable even up to 3 months postpartum. But at the end of the day, the primary outcome basically was similar in both arms. So antepartum and postpartum weight-adjusted intermediate dose did not reduce the risk of VTE compared to a fixed dose in pregnant women with a history of VTE. What about the safety results? So bleeding, major bleeding was similar in both groups. 23 patients in the intermediate versus 20 patients in the low dose, accounting for 4% in each group, had a major bleeding. And most commonly, the major bleeding happened in the early postpartum period. So the conclusions of this study was that among pregnant women with a history of VTE, weight-adjusted intermediate dose low molecular weight heparin was not superior to the fixed dose. So therefore, low dose low molecular weight heparin should be used during the pregnancy. However, in a post hoc analysis, there was a suggestion that intermediate dose may be more effective than low dose in the postpartum period. But this study was not designed to answer this question. So my patient decided to participate in the Highlow study and was randomized to the low dose. When she achieved 36 weeks of pregnancy, expressed her desire to have neuraxial anesthesia. What will be the recommendations? A, continue with low dose, low molecular weight heparin, and tell the patient to stop anticoagulation when she has signs of labor or rupture of membranes. This was a requirement from the protocol. B, stop anticoagulation and restart in the postpartum period. C, continue low dose, low molecular weight heparin and plan the delivery. And D, switch to unfractionated heparin, 5,000 units twice a day. The correct answer will be A. We can also consider the answer D. But my patient, upon discussing with her OB, made a decision to switch to unfractionated heparin, 5,000 units every 12 hours. So what the Society of Obstetrics and Anesthesiologists and Perinatologists Task Force recommends. So if a woman is taking a low dose, which is considered 5,000 units of unfractionated heparin 2 or 3 times a day, and the interval between the last dose and the placement of epidural catheter or spinal is 4 or 6 hours, then the patient can go ahead with this procedure. If the interval is less, a documentation of the coagulation status, meaning a normal APTT or anti-10A level, has to be documented and normal. On the other hand, if the dose is intermediate, which is considered a dose of less than 20,000 units in 24 hours, the requirement will be an interval of 12 hours or higher, also with the documentation of a normal APTT or undetectable anti-10A activity. On the other hand, if the patient is taking a high dose, which is considered more than 20,000 units per 24 hours, the interval should be 24 hours or higher, again, with documentation of a normalization of the APTT or undetectable anti-10A activity. So what about for low molecular weight heparin? For low molecular weight heparin, with a dose that is a low dose, the requirement interval is 12 hours. With an intermediate dose, the requirement is not yet established. They consider between 12 or 24 hours. And for a high dose, the interval has to be 24 hours or higher. So based on this, the Highlow study had a sub-study which was to describe the onset of labor and use of analgesia in women using low molecular weight heparin and to compare practices between the intermediate and the low dose. So for this study, there were a total of 17 women with a viable pregnancy, which was defined as a pregnancy of 24 weeks or more. So these are the results. So for women who had a spontaneous onset of labor, in the intermediate dose was 39% and 49% in the low dose, 37 versus 48% were able to have neuraxial anesthesia. However, 61 versus 82% had been actually eligible for this procedure. If they had a planned delivery, which was most common, 61 versus 51%, the neuraxial anesthesia actually was similar in both arms. However, the eligibility was 81% in the intermediate dose versus 93% in the low dose. So the conclusion of this study was that women who actually are on an intermediate dose are less likely for neuraxial procedures based on the required time interval. I think this is a very important information to tell patients, specifically at least in New York, where the rate of neuraxial anesthesia is quite high. So my patient restarted anticoagulation with enoxaparin 40 milligrams daily, 24 hours after giving birth. She wanted to breastfeed. What anticoagulation will be safe for lactation? These are all possible anticoagulants, and what is safe for lactation includes warfarin, as it's not detectable in the breast milk. Low molecular weight heparin and unfractionated heparin and fondaparinux are also safe, keeping in mind that there is a small excretion of low molecular weight heparin in the breast milk. And then what about the DOACs? So there are differences between the DOACs, as you can appreciate here. Dabigatran and rivaroxaban and edoxaban had only a small amount through the milk. On the other hand, apixaban has a high excretion. So at the end of the day, we had to make the decision individualized, and the appropriate dose should be based on the woman's clinical condition first. So I'm going to switch now to acute VTE during the pregnancy. This is another patient that I followed in my practice. She was a 36-year-old female that at 24 weeks of gestation was admitted to labor and delivery with right lower quadrant and flank pain. She underwent ultrasound and MRI of the abdomen and the pelvis, and we couldn't identify the reason for the clinical manifestation. Over the next few days, the pain extended to the left leg and was associated with problems in ambulation. 6 days from the initial presentation, she had an ultrasound of the left leg, which showed a slow flow without any evidence for deep vein thrombosis. 24 days after the initial presentation, an ultrasound showed a occlusive thrombosis of the left lower external iliac vein, shown here, as well as the femoral popliteal and saphenous vein. So what are the recommendations from the different societies in terms of acute treatment of venous thromboembolism during pregnancy. So the American College of Chest Physicians, the American Society of Hematologists, the American College of Obstetrics and Gynecologists, and the Royal College all recommend low molecular weight heparin, either once or twice daily. There are few differences. For example, the American College of Chest Physicians also suggests to modify the dose in women who have a high risk for bleeding or osteoporosis. Interesting thing is that the American College of Obstetrics and Gynecologists suggests to actually, after 3 to 6 months of therapeutic dose, decrease the dose to either an intermediate or a prophylactic dose and continue with that dose for 6 weeks postpartum. So what about routine anti-10A monitoring? In general, none of the societies recommends to do routine anti-10A monitoring except for the American College of Obstetrics and Gynecologists, that in women who are on low molecular weight heparin twice daily, a peak level anti-10A maintaining a therapeutic range between 0.6 and 1.0 should be done. If the woman is on a higher dose, the therapeutic range is between 1 and 2 units per milliliter. And the Royal College recommends in women with extreme weights, defined as women less than 50 kilograms, women more than 90 kilograms, or in the event that a woman has renal insufficiency with a creatinine clearance less than 30, and if they are on enoxaparin or dalteparin, an anti-10A level should be checked. And the same with women with recurrent VTE. What about doing catheter-related thrombolysis? So at this point, the American Society of Hematology suggests against doing this procedure. However, it should be considered in patients who may have limb-threatening deep vein thrombosis, keeping in mind that the procedure actually exposed the fetus to radiation as well as increase in major bleeding. And this is based on data from the ATTRACT trial. What about putting an IVC filter in the pregnancy? This is a retrospective systematic review of 9 studies in which women who were pregnant had a filter placed. So the indications to put a filter in pregnancy is the same as the indications of putting filters in non-pregnant patients, and include the contraindication for anticoagulation, so in a person who is actively bleeding, if there is a VTE despite proper dose of anticoagulation, and it's important to address that the location of the filter appears to be preferable in the suprarenal location because there is less compression in that area of the inferior vena cava from the gravid uterus, and also the ovarian veins are below, and sometimes the clots can actually form on the ovarian veins. So my patient was admitted to the hospital and was started on enoxaparin 1 milligram twice a day. After the 4th dose, we checked an anti-10A level and was subtherapeutic. The reason why we made the decision to check the level was the extensive thrombosis that she had and the delay in the diagnosis. We decided to increase the dose to 17 milligrams twice a day, and the anti-10A level became therapeutic. While in the hospital, she developed shortness of breath, and we did a CAT scan angiography which showed no pulmonary embolism. The patient was discharged from the hospital with 2 subsequent anti-10A level checked, and they were on the therapeutic range. She was scheduled for induction at 38 weeks of gestation, and because of the therapeutic dose, we decided to stop the anticoagulation 24 hours prior to the induction, and this allowed the patient to have epidural anesthesia. She was able to have a vaginal delivery with an estimated blood loss of 600 milliliters. 24 hours after giving birth, she resumed the treatment dose with low molecular weight heparin and continued for a total of 3 months. At the end of the anticoagulation, we did another ultrasound that showed residual thrombosis in the femoral and the popliteal veins. So the take-home messages are the following. The risk of VTE in pregnancy is increased due to physiologic, anatomic, and hypercoagulable factors. Postpartum thromboprophylaxis is required for all women with history of VTE. Both antepartum and postpartum prophylaxis is indicated in women with estrogen-related VTE, unprovoked VTE, or high-risk thrombophilias depending on the family history. For now, low-dose, low-molecular with heparin is the preferred dose for thromboprophylaxis during pregnancy. And low-molecular with heparin either once or twice daily without routine anti-DNA monitoring is recommended for the management of acute VTE in the context of pregnancy. Thank you very much, and I will be happy to answer questions.
Thank you so much, Maria. This was a very important study that answered the question on appropriate low molecular heparin dose for VTE prophylaxis and pregnancy. Of course, for the postpartum period, we'll have to wait for future studies, it sounds like. Everyone is very excited about this topic, and we have several questions that were sent to us ahead of time, and there are more in the chat. So I do have a question for you. The first is that the ACOG guidelines seem to rate some high-risk thrombophilias as low risk. This person is stating that their hematology specialists disagree with those recommendations. So how are we to reconcile the two?
Right, so I think there is some discrepancies, but in my opinion, high-risk thrombophilias will be women who are homozygous for factor V Leiden or homozygote for prothrombin gene mutation, or women who have combined thrombophilia. So for example, factor V Leiden and protein C deficiency or antithrombin deficiency. Antithrombin deficiency, in my opinion, is already a high-risk thrombophilia. In terms of the protein C and the protein S, I think homozygosity for those definitely are high-risk thrombophilia. Heterozygosities, I'm not in favor calling that high-risk thrombophilias. And the other issue was antiphospholipid antibodies. So I think also there is a higher spectrum of the antibodies. I think women who are triple positive, so meaning that they have a positive lupus anticoagulant, anticardiolipin, anti-beta-2 glycoprotein, they could consider to be definitely at a higher risk compared to someone that is maybe single positive without the lupus anticoagulant.
Yes.
Great. Yeah.
Thank you.
Question. Yeah. Okay. So I have another question. This one came from the Q&A box. So in light of the recent ASH guidelines that just came out about thrombophilia testing, when do you recommend thrombophilia testing in pregnancy or women of childbearing age who wish to become pregnant? And do you recommend in patients with just a family history or patients with the personal history of VTE? So like, when do we test, like who do we test first off? And then if you can just highlight which specific clotting disorders you would test for in these patients.
Right, so this is always a very difficult question to answer. And I think we have to individualize each case. I think if I have in my practice or consultation that someone comes in and they are telling me, yes, there is a family history, but I don't have any information about what is the specific thrombophilia that the family history has, I am a little bit of hesitant, to be honest with you, to start testing blindly. I usually don't do that. I try to tell the patient to try to find more information, and if they are able to retrieve that information, I will be more targeted to the specific, if they find the thrombophilia, to the specific thrombophilia. But I spend time mostly kind of educating the patients on signs and symptoms of VTE. And even if they don't have, let's say, the specific thrombophilia, already having a family history per se, with or without a title of a thrombophilia, I think that is already an important risk factor. So I'm a little bit cautious about when to do thrombophilia. On the other hand, if someone comes in already with a family member with unidentified thrombophilia, let's say that my mother had a factor V Leiden and she was tested because she had a DVT after pregnancy. So in that scenario, I know already which one to choose, and then I usually go ahead and do that.
Great. Yeah, excellent. I think it's helpful if you can really understand the patient's family history, and like if you have the identified coagulopathy, it probably helps a lot more than just doing the $1 million workup that I call it. So
I don't like to do that personally.
No.
I don't like to do that. Yes.
Maria, this question is related to the ISTH recommendation that if a woman wants to become pregnant, that they should switch from the DOAC to low molecular weight heparin or vitamin K antagonist. So the question is, I thought that vitamin K antagonists were teratogenic, so why wouldn't we just switch the patient to low molecular weight heparin? Why would we switch them to warfarin?
Right. I agree with that comment. This was written in 2016. I'm not sure why they made that kind of recommendation. I mean, it's unlikely that we are going to switch a patient from a DOAC to a vitamin K antagonist. There is one scenario that I'm thinking that definitely if a patient has antiphospholipid syndrome, right, the patient should be on a vitamin K antagonist, specifically if they are triple positive or if they had an arterial event. So that will be a reason maybe definitely to switch from a DOAC to a vitamin K antagonist. The other thing that, and I have encountered also this in my practice, I remember one of my patients who actually had a cerebral sinus venous thrombosis in pregnancy when she was about 8 months of gestation, and actually she had a thrombophilia testing done, and she was compound heterozygote for factor V Leiden and prothrombin gene mutation. And then she decided to continue with the anticoagulation with the vitamin K antagonist with warfarin, and then became pregnant, and she was on the warfarin. So what we did is actually reverse the warfarin with vitamin K, and then the following day, she actually started with low molecular weight heparin. But it's tricky also because when you put them on low molecular weight heparin, many times you don't know how long it's going to take them to get pregnant. So they may be injecting the anticoagulant for months and even nothing may happen. So I try not to do that. I offer patients kind of choices. So one choice will be to do that, to switch, again, not knowing when they are going to become pregnant. Another possible choice is that I always ask, are your periods regular? Because if your periods are regular, if you miss just one day, immediately check a pregnancy test. If the pregnancy test is positive, call us immediately, and then we will put you on the low molecular weight heparin. So I give them this, and then they make the decision.
Yes, thank you. I encourage this person to read the fine print in the guidelines. And this would be temporary because, as you're stating, it could take a while for the person to become pregnant. And of course, with the injections, it does get to be tedious, and we want therapy that someone is going to be able to keep up with. And so this is just to be used during the time period while they are trying to become pregnant. On that same vein, you mentioned switching to the vitamin K antagonist. In what circumstances might it be appropriate to use a vitamin K antagonist in pregnancy?
Right. So that is basically in women who do have a mechanical heart valve. There are different schools of thought about that. So one of them is definitely avoidance of the vitamin K antagonist from week 6 to week 12, because that's when there is significant, problem with embryopathies. There is the second trimester also could be tricky because, there could be also the possibility of fetal hemorrhage, intracranial hemorrhage. But definitely what is done for these women usually is to use the heparin or low molecular weight heparin at the beginning from 6 weeks to week 13. Then they can be switched to the vitamin K antagonist, and by 36 weeks back to the heparin. I had an experience once with a patient of mine who had a mitral and aortic valve mechanical. And one pregnancy, the first pregnancy actually was complicated with the fetus having an intracranial hemorrhage when she was on warfarin on the second trimester of the pregnancy. And what happened with her is that she forgot one dose and then she doubled the dose the following day, and this happened. She became pregnant a second time, and she called, and between the cardiologist and I and the OB, we decided to just use the low molecular weight heparin throughout the entire pregnancy, actually checking the anti-10A level and maintaining the activity between 1 and 1.2 international units per ml. And she had a successful pregnancy, and on admission, she actually was switched to unfractionated heparin, was stopped 4 hours prior to delivery, and had healthy delivery and on postpartum period, and then she was switched back to warfarin. But these patients are, they need to have a multidisciplinary approach. It's not just a hematologist, they need to have a cardiologist, a high-risk OB, and to make sure that we can offer the best outcome for these patients. Other than that, besides mechanical heart valves, I don't see any other indication to be on warfarin during the pregnancy.
Yeah, on a similar thread, talking about injectable anticoagulants, can you talk a little bit, Maria, about what to do in a patient who's HIT positive? What's the role of fondaparinux? When can we use it? When can we not? Like, how do we treat these patients if heparins are not, if they're not a viable option?
So recently I have an experience like that too, of a patient with who had developed, like about maybe 3-4 years ago, postpartum actually. She had developed a large DVT and then had heparin-induced thrombocytopenia. Not heparin, actually was low molecular weight heparin-induced thrombocytopenia with enoxaparin. And then became pregnant, about maybe already like 12 months ago. She became pregnant and she was on fondaparinux because she never had actually stopped the fondaparinux. So during the pregnancy, we were monitoring her with the fondaparinux. The main issue for us as a group was how do we deal with the delivery period, because the fondaparinux, the half-life compared to the low molecular weight heparin is longer. It's approximately between 18 to 21 hours. So the dilemma was, when are we going to stop this agent? So we made a decision to stop it approximately 4 days before the delivery. She did well. Actually, she was pregnant with twins as well. And then we were able to restart the 24 hours after, and she did well. And so I think there are ways to do the things, but again, I think to me, it's very important to, like, every individual that is caring for a patient has communication. Communication is the most important thing to care for patients. You have to pick up the phone, you have to do a multidisciplinary conference, whatever it is, but I think is the most important thing, to be on the same page. Everybody has to be on the same page.
Absolutely. And there's so many specialties that are usually involved in these patients' care. You know, you've got your hematologist, you've got your OB gynecologist, you've got your cardiologist. There's so many different specialties, and getting everyone on the same page is so important. So thanks for the answer to that. That's a tough one. Naomi, do you have another question?
We have so many questions.
I know. Good one.
This is a popular topic. Yes, the next question is related to unfractionated heparin and low molecular weight heparin. What doses are recommended in pregnant patients with low versus high thromboembolic risk in the antepartum and postpartum period? And then there's some confusion, it seems like, between the prophylactic dose and intermediate dose and adjusted or therapeutic dose. So what are the recommendations for a patient who's high risk and needs the anticoagulant in the antepartum and the postpartum period?
So usually I personally don't tend to use fractionated heparin, but I think definitely there are situations for example, by approximately 36 weeks of gestation, sometimes the obstetricians prefer to switch from low molecular weight heparin to unfractionated heparin because the possibility of offering the neuraxial anesthesia, and even sometimes they are concerned about the 40 milligrams, so the preventative dose of unfractionated heparin, because they may not have, the women may not have the 12-hour interval. So it's, in my institution, it's a common thing that women are switched from, let's say, if they are on 40 milligrams, usually the dose will be 5,000 every 12 hours. Sometimes, depending on the weight, you may consider a higher dose, 75, 100 twice a day, or even up to 10,000 twice a day. Okay, so that could be considered as a prophylactic, will be 5,000 twice a day to 7,500 twice a day. And then 10,000 twice a day is already considered an intermediate dose, and more than that is already considered to be a therapeutic dose.
Got it. Great. So a pregnant woman, so she gets a VTE during her pregnancy, and we're treating her, of course, for the VTE, we're giving her low molecular weight heparin, and say she had the DVT early on in her pregnancy. We'll obviously continue the anticoagulation for the duration of the pregnancy, as well as that 6 weeks postpartum, correct?
Correct.
And then we treat them like a provoked VTE, correct?
Mm-hmm.
Great. Yeah, that question came in. I just wanted to clarify that, but we would treat them for the typically 3 to 6 months. Is that kind of the
Correct. So, okay. Right, but as you say, like if the VTE happens early in the pregnancy, let's say 10 weeks of gestation. So, of course, the period of acute treatment, according to guidelines, is 3 to 6 months. But the issue with these women is that the risk persists because they continue being pregnant, right? Specifically, if the clot happened when they were very early in the pregnancy. So one of the things that I placed on the one of the slides is that the American College of Obstetrics and Gynecologists, after that period of time, they actually are suggesting to diminish the dose to an intermediate or a prophylactic dose. And this is not, there is not a clinical trial that is answering that question. And I think that's an important thing, specifically because the risk is there. It hasn't been eliminated. I don't know how to answer right now that question, whether that's the proper way to do with a patient, to lower the dose. I'm not sure.
There's a lot we don't know still.
Yes.
Looks like we have time for maybe one more question. Naomi, you want to tee it off with one more good one?
Yes, let's see. This one's related to monitoring. So as you mentioned in the presentation, most guidelines appear to discourage anti-10A monitoring. When, if ever, might it be appropriate to draw anti-10A levels, and under what circumstances, if you draw that level and it's a little bit off, should we be adjusting the low molecular weight heparin dose?
Right. So to me, one of the main reasons to do that will be in, again, women with mechanical heart valves. I definitely will check an anti-10A level. And if it's below what is considered to be, so the range for that type of indication is not 0.6 to 1.0, tends to be a higher level because there were studies done that if the level is closer to the lower end of the therapeutic range, there is an increased risk of valve thrombosis, which will be catastrophic. So I definitely will do the anti-10A level in that scenario. Another scenario that I have encountered is women with hereditary antithrombin deficiency who had a prior history of VTE and they take chronic anticoagulation. So we put them on low molecular weight heparin. But because they have the antithrombin deficiency and low molecular weight heparin and unfractionated heparin are indirect thrombin inhibitors, meaning that they require antithrombin to do the effect, then usually these patients tend up to require a much higher dose according to the, so for example, if someone is 60 kilograms, they may even need to get 120 milligrams twice a day. So in that setting, I also tend to monitor the anti-10A level, and depending on the level, adjust the dose. So I can see these two scenarios. Another potential scenario will be like, let's say that this woman is taking low molecular weight heparin, and despite that has another thrombotic event in the pregnancy. I will, in that scenario, check. I don't check if I am not gonna do anything with the information. I try not to do tests alone just for doing a test. If I do a test, it's because I'm gonna make a decision based on the results of the test.
Yes, that makes perfect sense. Thank you so much, Maria.
You're welcome.
I wanted to thank Maria for being with us this afternoon. I do have some announcements for you from Anticoagulation Forum. Today's webinar recording will be available in our webinar archive and on the YouTube channel in the coming days. Do you know about these centers of excellence? Are you an anticoagulation center of excellence site? If not, you can learn more at acforum-excellence.org. AC Forum also offers the Resource Center, which has hundreds of resources anywhere from broad guidance to very specific protocol examples of excellence. AC Forum also offers an online literature update that highlights articles published on anticoagulation related topics. Visit these centers of excellence today. If you haven't seen it yet, AC Forum has created a new webinar archive on YouTube. You can subscribe today to the @Anticoagulation Forum account to be notified when new videos are added. Bootcamp registration is now open. Join us for this compact 2-day live virtual meeting on October 13th and 14th with extended on-demand access for 30 days. This year's bootcamp has 16 presentations and 12 hours of CE credit available, so do not miss this opportunity. If you could not join us at AC Forum's live conference in April, the recorded content is now available for purchase. For $399, you can have individual access to 27 presentations by 33 experts and receive 16 CE credits. Access is available until July 31st, and CE can be claimed until August 31st. So please register today. Finally, a big thank you to our webinar sponsors, and thank you to all of you for joining us today. We look forward to seeing you at the next webinar.